Hello and welcome. My name is Carol Carter, and I'm the founder and CEO of Global Minded. And welcome to our monthly health equity events hosted by Dr. Monique Butler and Dr. Pierre Theodore. We meet here once a month and we talk about timely topics. And we are so thrilled this month that it is the International Month of Women. And we have some of the most extraordinary women in healthcare assembled today, and we're so delighted to bring them to you so you can get to know them and that they can provide inspiration for you from really this difficult year we've come out of into where we're going. So I'm going to just start by sharing a little bit about Global Minded. We're about creating a capable, diverse talent pipeline to get more women, people of color, underrepresented populations into the education, economic mobility, and the leadership pipeline. And we do that in a number of ways through an annual conference, which will be virtual this year. And it's actually going to be called Reboot Resilience: Rebound Remarkable. And every single session will be about how we can rebound with the best that is within us and come out better because of the difficulties of last year than the people we were before we had to go through this. So that's what it's about. And there'll be a student on every panel. And we hope that our guest today will also join us for that. It's going to launch during Earth Week, goes for 10 weeks until the middle of June. So that'll be virtual. And next June, 2022, we're going to be live in Denver. So we want to make sure you all have that on your calendars. So without further ado, I'm going to turn it over to Dr. Butler and Dr. Theodore. And thanks to all of you for joining us today.
Okay, I think I'll kick it off. Good afternoon, everyone. I am Dr. Monique Butler. As Carol just mentioned, I am just excited to co-host these webinars every month with Dr. Pierre Theodore, with our goal of, highlighting and showcasing health inequities, but also putting in place actionable items to decrease the health disparities that we face in our country. So I am currently the Division Chief Medical Officer of the North Florida Division of HCA Healthcare. I have been in the role here for about actually 90 days. And prior to that, I was the Chief Medical Officer of Swedish Medical Center in Inglewood, Colorado, which is where I met Carol, and has been a part of Global Minded since that time. I'm going to turn it over to Dr. Pierre Theodore to introduce himself, and then we will have each of our panelists introduce yourselves, give us just a quick 2-minute overview of why you are an amazing woman in healthcare. This is Women's History. I like to say Women's Her Story Month. And getting close to the end of the month, we really are excited to showcase our amazing panel today. So just give us a quick overview of who you are and what you do. So I'll turn it over to Dr. Pierre Theodore. Hello, Pierre. How are you today?
Hi, Dr. Butler. Thanks so much for the introduction. And there are times in life to be relatively quick and turn over to the field to those experts that really can speak to the power of being a Wonder Woman in healthcare. And that is my intent today. We at J&J, I'm a Vice President of Medical Affairs at Johnson & Johnson. I'm responsible for overcoming the barriers of access and affordability to medical devices in low and middle income countries. And I also lead programs that are focused on equity. And it's important for me to acknowledge the areas where I have blinders, and also to look for that intersectionality and commonality among all groups of either marginalized patients or those that have traditionally, through some legacy of discrimination, not had access to the delivery of healthcare or leadership roles in healthcare. So with that very brief introduction, I am so delighted that Dr. Kiser and Dr. Cook and Dr. Nagori and Dr. Chin are able to join us today to tell us a little bit about their organizations and their own individual journeys, and then thereafter to engage in a conversation, hopefully informed by some of the questions from all of you who have joined us today in this discussion of the power of women in healthcare. And with that, I will step back, and perhaps I can at this point turn it back over to you, Monique, to help to drive our introduction of our guests.
Sure, thank you. How about we start with Dr. Eliza Chen? Good afternoon, Dr. Chen.
Dr. Chen, turn your mic on.
Dr. Chen, you are
Got it.
still muted. There
Okay,
you go.
how's that? I'm
That's
sorry.
better.
Thank you so much. What an honor to be here. Thank you, Dr. Butler, Dr. Theodore, for that wonderful introduction. My name is Dr. Eliza Chin. I'm the Executive Director of the American Medical Women's Association. If you had told me 20 years ago I'd be speaking on this panel with the title of this panel, I never would have believed you. So to all the students who are watching, I want to just tell you anything is possible. I thought I had a pretty standard path to medicine, going through the pre-med years to medical school residency, and I trained in internal medicine. Eventually, because of my interest in women in medicine, ended up editing an anthology on writings by women in medicine. And that got me interested in women in medicine, eventually found the American Medical Women's Association, became a volunteer leader. I spent many hours of my volunteer time working in the association on various committees, eventually becoming president in 2010, 2011. And a few years after that, an executive director position opened up internally, and I was really at the right place at the right time. And I have to say that big jump in my career really has opened up just so many possibilities and the opportunity to work with so many different people to advance healthcare, not just for individual patients or people in my own practice, but on a much larger scale, partnering with organizations, launching initiatives. And that has been, I feel, so empowering. So I'm humbled to be on this panel. I don't feel like I'm as much of a Wonder Woman as many of the others here on the panel, but I want to inspire all of you in your journeys in healthcare, medicine, or whatever you want to do, to be open to the possibilities. In my situation, opportunities opened up, and I went for them. I worked hard. I poured a lot of volunteer time, which ended up leading to something bigger. And so just want to encourage you, no matter where you put your efforts, whether it's paid work or volunteer work, as long as you follow your passion, you will make a difference. Thank you.
Excellent. Thank you so much, Dr. Chen. And you are indeed a Wonder Woman, and you deserve to be on this panel. I'm so happy to meet you via Zoom. I'm going to move quickly to Dr. Margie Cook to give just a quick overview and introduction of yourself. And you definitely are a Wonder Woman. I know you personally. Tell us more about your story.
I really am not a Wonder Woman. I give it all to my mom and to my daughter. See, because I learned a lot from up and down as a sandwich person. I started off as the 5th child of sharecropper. My daddy was a sharecropper in Beaumont, Texas for a while until he got wise and decided to get him a job also working for the white man, but at least he didn't get raped off by doing so. My mother started us understanding that you are a wonderful person, not a Wonder Woman, but you just a wonderful person made beautifully, and you got a brain, and so go for it. My parents were not able to go past 8th grade because we were in the Cotton is King South, where slavery had only been 3 generations ahead of me. So the problems that we dealt with were so horrendous, as we are dealing with some right now, that my mother encouraged us to do better than she did. She said when the slaves left slavery, the white man said, do not educate them, don't let them live around you, and don't give them good jobs. My mother said, don't pay that any attention. You get the best education as you possibly can. And that's what I sought out to do. I went to the university in my hometown to get into the medical profession, and was told that they didn't accept any Indians, Jews, or dogs. So that was my entree to leave Texas and go to Colorado, where I got my education. So I've been very humble to have had the opportunity to study with the nuns, with the monks, and with the Christians. So that has given me a rounded idea of how to become humble. And I tell the students often, be as humble as you can, especially when somebody called you a name that you're not. Just take up and show them that you can do the very best, you can give the very best care that they have ever received. So I welcome the opportunity to speak today. And again, I do not feel like a Wonder Woman. I just feel like stuff that I'm supposed to do.
Yes. Amen. Thank you for sharing that, Dr. Cook. Dr. Saya Nagori, and please make sure I'm pronouncing your name correctly. If you can introduce yourself and give us a brief overview of what you currently do now.
Sure, thank you. And I'm honored and humbled to be amongst everyone on this panel today. My name is Dr. Saya Nagori. I am an ophthalmologist, and I, about 6 years ago, got into telemedicine and started a telemedicine company in the ophthalmology space. About 2 years ago, we actually pivoted from ophthalmology to women's health, and now SimpleHealth, and Dr. Carrie SiuButt is actually on as well. She's the CEO of SimpleHealth, is now a fairly large operation, over 75 people, and we're serving women across the country to help them get better access to reproductive care. I also have a media initiative called FemHealth that was a lot partially spurred by my own personal journey in medicine. I went through some women's health issues myself with fertility and some PMS and PMDD symptoms, which sort of inspired me to create a platform that created a place where women and persons could go to get more education on women's health topics that were digestible, but also from reliable sources. That's what FemHealth is, and really the goal there is to increase health equity by increasing health literacy, and so that's sort of how we are just trying to champion health equity there. And I echo a lot of what the previous two speakers have said. I think if you just work hard and just try to stay focused with those blinders on, you really can accomplish a lot.
Excellent. Thank you very much. Dr. Lisa Kiser, good afternoon.
Good afternoon. I am very grateful and appreciative to be here as well. I am Lisa Kiser. I live in Tucson, Arizona. I am a native here. And I actually love the title of this presentation because I am a certified nurse midwife and a women's health nurse practitioner. I'm also on faculty for the College of Nursing at the University of Arizona. And so I think the title really reflects the truth that we are not the Wonder Woman, that we are Wonder Women. And that in our work, in the work that we do, what I'm most excited to share is to say that for all the students there, that our work is always grounded in our community. We live in a very rich area. We live in the borderlands. We are partnering across that border. We are changing that border and transforming that border. Some of the stories I want to share are the work that we are doing with the faculty and clinics in Mexico, as well as the clinics that serve our migrant population here. But that love of community, that understanding of place, the role that women play in our communities, the role that they're playing, as well as the people in terms of our vision of participatory healthcare, and that we partner with our patients and that we find ways that they are leaders in the care that is being provided in our community. I want to encourage and animate, and as we say in Spanish, darse ánimo, that we really motivate people to say our role as educators is to replace ourselves and to put you into leadership roles as you are transforming the education system while you are as a part of it. So we are doing so many great things, but it is the Wonder Women that we are here. And in that sense, I am so happy to be here with the rest of you, because I feel that we are each bringing a piece to the conversation. And I'm hoping that we're modeling what it is that we're planning for the future and making happen now.
Thank you. Thank you very much. And I love that. We're all intertwined together, right? And we bring each other up. Thank you. Carrie SiuButt, good afternoon.
Hi, good afternoon, everyone. As I mentioned, I am the CEO of SimpleHealth, and I joined a week and a half before the pandemic. And while I think the women here are Wonder Woman, I have to say myself, I am literally a bionic woman. And I say that because my story is very unique. One of the reasons why it's a pleasure and honor for me to sit on this panel is not only am I half Black and half Chinese, I'm also disabled. I suffer from a disease called dystonia in 15 years. So I can't walk, I can't write, I can't speak, but 15 years ago, with the miracle of stuff that Dr. Theodore spoke about, I had deep brain stimulation. And so I am the bionic CEO woman. Not sure you guys have ever had one of those before, but here we are. And so one of the reasons why telemedicine is so important to me and why I was drawn to taking on this challenge is the idea that we can give everyone equal care and equal access. And so as someone who has been discriminated against my entire life or judged because I had a limp or I slurred, I've had doctors ask me, are you drunk? I'm like, no, I'm not. So it is a very, I would say, messy system out there. And I would say for everyone on this audience, your careers are never linear. And I think everyone here has said, just keep on going with what you want to do. I've always wanted to be a CEO since I was 7 years old. I told my parents that I wanted to do it. And while everyone told me why I couldn't go to Stanford, why I couldn't, do this, why I couldn't go on Wall Street, I always thought to myself, well, what can I do? And everyone for so many years has said, Carrie, you should never be a CEO. It's way too stressful. It'll, fire off your neurological system. I think every problem has a solution. So I figured out how to manage my neurological system. And I just want to say to everyone on the panel, just don't take the no's or you can't, because I think every person can. And I am living proof that, 15 years ago, I said to the universe, if I can ever walk again, I will dedicate myself to health and wellness. And I have to say, you can't go back on a promise when you look at the big guy upstairs. And so here we are today. And my goal here is to really change the way women access reproductive health care in this country. Just a small goal, but I feel like I'm up for the challenge. So thanks for having me here.
Great.
Awesome. Dr. Theodore, we have an all-star panel here, and without further ado, I want to just dig right in. Any comments you want to make after you've met each of our panelists?
Well, I think my first comment is that we are definitely in the presence of some Wonder Women hearing these stories overall. And just for me and for many of our listeners, just to listen into your stories and the organization that you founded are very important to me personally. So thank you for all that you've done. And I guess the first question, if I could sort of jump off, and Dr. Chin, I thought I might address this to you. When you think from your organizational standpoint about structurally addressing issues related to health, to equity and gender parity, what are some of the priorities that the American Medical Women's Association have really put at the forefront as strategic objectives this year? And have you had any objectives that have come out of the pandemic that have changed your sort of approach to health equity?
Yeah, thank you so much for that wonderful question. So AMWA's mission is to advance women in medicine, advocate for equity, and ensure excellence in healthcare. So the equity piece is a very big part of it and actually overlaps the other two. And so I think you asked many different questions in that one question, but I'll try to address all of them. So definitely, out of so much that has happened in the past year, both with the pandemic and then with the awareness of racism in the country, particularly structural racism, there have been a lot of initiatives even within AMWA and how we are stepping up to address these challenges. So related to gender, one of the big things that we've always been working on is the gender gap in leadership. So the pipeline is fairly robust. We have now just over 50% of women entering medicine. But if you look at the ranks in medicine, particularly in academic medicine on leadership, you see a sharp drop off and all the way to the top leadership where just 18% of medical school deans are women. And we just had a conference this past weekend where we actually had 8 of the medical school deans, women medical school deans, speak about their experience and their leadership experience. So one is fixing that gender gap in leadership. But in addition to that, we realized that even within women in medicine, we need to make sure that we are diverse and representative of all women in medicine. And so there, even though the pipeline looks pretty good, the numbers of the different groups, we still have underrepresentation. So one of our big efforts this coming year is going to be, how can we improve the pipeline so we have the diversity that we need, and reaching out and providing more opportunities, more support for women of color, so that they can have the same opportunities. And I think one of the other areas that we are working on related to this is the anti-racism work that I think so many are working on in different sectors, but we have realized that coming out of all the experiences last year, that within healthcare, there is still significant amount of structural racism. There's a lot of education and awareness that's needed. We've started monthly discussion groups. We have looked internally at even our systems and how we can make sure that we all become more aware and work to provide solutions to that. And I'll end on the final note that, we have a diversity and inclusion section within AMWA. And as we considered where to put this, do we call it a committee? Do we call it something else? We realized it really needs to be something baked into everything that we do. So we call it a section, so that every initiative, we will have that lens and look through to make sure that we are addressing things in the proper way from a diversity, equity, and inclusion standpoint. So sorry, that was a long answer, but I think I hopefully covered most of what you asked for.
Thank you very much. Monique, I'll turn the next set of questions over to you.
Yeah, thank you. Dr. Kiser, you mentioned during your intro that, we're Wonder Women on this panel and that we're really intertwined. I'd like to know from you, and then also from Dr. Cook, and even others who would like to jump in. Tell me about, after meeting the other panelists, what can they do to help you with closing the equity gap in your current role? And how would you like to involve them in the next steps?
No, I think that is the power, though I'm not a big fan of Zoom, of being able to meet people that you would not normally get to meet. So I think we really do act locally here in the border. We have a lot of initiatives that are critical. So first, at the University of Arizona, we joined together and created a coalition of all the health sciences so that we could respond to the issues of migration. So during 2018 and most of 2019, we had anywhere from 200 to 300 migrants crossing into Tucson a day. And so we wanted our students to be able to be leaders and help to respond to this. We created an interprofessional working group called Milagro, which we have kept going. And we're now seeing that the numbers are going up. And so I feel like when you look at us as a panel, there's that ability to just say, where can we get support at the state and national level for some of the work that we have to be doing? And I think each of our communities have those critical, essential things that we have to do. But for us at the University of Arizona, we're also seeing that the pandemic has hit our students particularly hard. So many of our students are either in our undergraduate nursing, but I also teach in our doctorate programs. And so to try and be a nurse during the pandemic and continue your education has been enormously challenging. So I'm already thinking of ways where we always need help with funding with our diversity, equity, and inclusion initiatives. I had a student this week that told me that for lack of $2,000, she most likely was going to have to drop out of her DNP program because she couldn't work full time and finish the program, but she couldn't leave her work because she had to have insurance and health insurance in order to participate and be in our program. So I think those connections, certainly I think I'm really focused on micro funding, meaning I also volunteer at Clinic Amistad, and we need $5,000 to start resuming cervical cancer screening and breast cancer screening because there was a 90% decrease in screening nationally because of the pandemic. And it's those places where you can have conversations and really say, who has the vision, who has the grants, who has the funding, and then who can support our work.
Well, let me jump in here. For one, I represent the Colorado Council of Black Nurses, and the reason we came together in 1964, we started talking because I had just graduated in 1963, and in all of my clinical places, there were zero Black nurses, Black doctors, Black pharmacists, or Black anything. So we found that there were 3 nurses of color in the whole metroplex of Denver. And we talked about how we could do this. So we decided to develop a thing called the Colorado Council of Black Nurses. Well, as a result of that, we have been the mentoring arm of the Black doctors, Black pharmacists, Black social workers, Black psychologists, and all of those folk, trying to help them to get students into their program. Now, they've just come out with a fancy word called equity in admissions. And I think Dr. Lisa and Dr. Chen, that if that were in place, really in place, then we would not need to beat on the same drum, because you need to have equity thinking. We already know that there's internal racism on all of our parts, or else I wouldn't have married a Black man. But there's so much other negativity when you start looking at the humanity of all of these folks. For number one, when you have patients of a certain group, Lisa knows that if they don't speak Spanish, if they don't understand the culture, the patient doesn't thrive. And so our major goal, all of our major goals should be equity in admissions of faculty, students, clinical people, even the frontline people, because we know the front desk is one of the major barriers of people of color. I just recently experienced it when I went up to visit a friend who was dying in hospice. And this lady wanted to know why was I there, and I was not a family member. And I explained to her, all Black folk are family members. So you just get over it, and I'm here to help this person die easy. So I think if we start looking at the whole equity, humanity piece, we could get along much better in educating our counterparts who are not people of color, because I think they need to be educated. My sister is always saying, I don't have time to educate these white folks. They should have learned that themselves. But I say to her that if you don't educate them, our patients and families will suffer, because some kind of implicit bias comes out, even though you're saying the right things and you're smiling and you're trying to act like you believe the right things. But when that bias come out, like, what do you people want? Well, we want the same thing you want. And when you're called upon, do you call all the white people, white students first and the Black one last? Do you ask the Black one to speak for all Black people? Those are some intrinsic things that we have to teach our counterparts. And we have to make a big push. You know how football is king in this country? We need to make healthcare king. And the way I see to do that is to ask the football players, the basketball players, the baseball players, and all those other players, soccer and whatever, to support one student of color throughout their educational career. They make plenty money, I think. And so if they go to the hospital with a bruise or a broken limb, then I think the hospital staff ought to say, it's good to see you here. We're going to give you great care. And if you appreciate the care, then you will donate one student all the way through. I mean, that's
Wow.
one area. And I think that we can do that by asking other organizations to corroborate with us so that we can have more students involved. My story is I started off in Beaumont, Texas, and the reason that I came to healthcare is my brother had rheumatic heart disease, and Beaumont, Texas at the time did not take care of people who were colored in any of the Christian hospitals, Catholic, Baptist, and Methodist, I think. So we had to move to Galveston, Texas, where they took care of prisoners and colored people. And so that was the only hospital in the state that would take my brother with rheumatic heart disease. As a result of that, all four of us girls behind him became healthcare providers. And we don't know if that was intrinsic or that we knew that if we span out across the country, we could make a difference. So I think that if we start thinking outside of the box as to how to educate people about us. Here lately, we've had some very positive things when I've been given the shots in the Black and brown neighborhood. People have said, what can I do to pay you back as a nurse? And I said, support another student. I'm 83 and I will be checking out here in about 18 years, I told the Lord. And so I would like to have somebody replace me. So if you really want to do something good, give me your email and I will send you the information on a student. So I think that's how we have to do it.
Yeah, Dr. Cook, I'm so thankful that you're on the line here today because, you brought out a lot of raw emotion and what you just mentioned. And I have to bring up what your sister mentioned around, this has been going on for so long. How much more can I do? But I think the other piece of what you mentioned is that collaboration and investing in students. Many of you, I think it was Dr. Kiser, Dr. Chin, and others mentioned around the structural racism. I mean, you mentioned your family being just 3 generations away from slavery. And, it does feel daunting, these conversations around health equity, because we've been in this position for so long. I want to bring in Carrie into the conversation. You mentioned, and thank you for being vulnerable and mentioning to us your disability. Some individuals in this country see their skin color somewhat as a disability because it's difficult to be able to, you can't change it. Talk to us, Carrie, about what Dr. Cook just mentioned and the structural racism and how it plays with the sort of prejudice that you've received from a disability perspective.
May I interrupt before she starts? I think the term should be misability because she has some great abilities, but it's miss, not dis.
Yes, ma'am. Thank you. I totally agree. Go ahead, Pierre.
I want to be you at 83. No, Dr. Cook, when you were saying that story, I raised capital and I was pitching to this woman one time, this whole VC firm. And this one woman got on the phone and she said, I don't understand your business model. Why don't those people just go to Planned Parenthood? And in my head, I was like, okay, that's not what she said. And then we were going on. She goes, I'm still confused. Like, isn't that the rural demographic? And don't those people go to Planned Parenthood for birth control? And in my head, I was like, this is 2021. Who says that term, those people? And so after I went, I spoke to her boss. It was for an investment of $10 million. And I said, as much as I need your capital, I will not be taking your $10 million. Because let me be clear here. I was one of those people where my parents made together $40,000, $50,000. They took us to doctors. They saved money for education. They may have never worn Louis Vuitton or anything else like that. And we live in a small house. But those people deserve proper health care. And that I realize is a systematic problem in our country, is that there is a have and have nots, and the have will call everyone else those people. And I said to her, I said, the reason why I'm sitting here today is that those people deserve the same health care that you deserve. You may get yours in Park Avenue, but I don't know why someone else can't get it, the same health care wherever they live. So, I tell that story because I might be too foolish sometimes, but I walked away from a check. It didn't sit right with me. I need to make sure that I can use my podium, my pulpit, to spread the word. And so, I have this game down now too, that when I go to the doctor, I look like I just roll out of bed, don't brush my hair. And the way people treat me, it's ridiculous. Like, just because I might look not wealthy doesn't mean that you have to treat me in 5 minutes and walk out the door. Now, I often wonder if I'm wearing Louis Vuitton and like nice purse and stuff, you'll probably treat me differently. And so there is so much systemic inequity in this conversation and the reality of the way we live, that I, through telemedicine, and I think Sia is one of the four mothers of being a believer in telemedicine, is that it takes away some of those inequities. And I like it to be asynchronous because we can't see each other. So no one can judge you. No one can discriminate you because of your shape, your color, the size, the way you walk. Because I've felt those systemic racism and discrimination. And I've decided that I'm going to work with my team through telemedicine to change the way that, specifically now women or our patients receive reproductive health care. But Dr. Cook, you know what? I got goosebumps when you were telling your story, because you were talking about something in 1964, and here we are today in 2021. Do the math, and it's the same BS that happened then that we're seeing now. It's just different, a little bit more passive probably, whereas it was probably overtly there. And so I would just say, because there's a lot of smart doctors here on this panel, is that as a business leader, I'm going to take it to try and change the way business is done, legislation and healthcare, to make sure that there's the discrimination can be a little bit eliminated, but it is alive and well in 2021.
Thank
Dr.
you.
SiuButt, could I follow up a question to you and Dr. Nagori, because you're both in the space of telehealth, as I understand. And could you discuss the concern that a digital divide could actually be exacerbated by telehealth efforts, and how it is that you try to create an inclusive telehealth experience along gender or ethnicity lines that is truly inclusive? So I was wondering if you could perhaps both comment on the role of telehealth in overcoming inequities, but also the potential for a digital divide to exacerbate inequities.
Sarah, I'll let you go first, Sarah.
Yeah, so I think that's a great question. One of the things that telehealth is limited by is that a lot of our patients need to have a credit card, right? So a lot of patients that need digital care or can use digital care may be limited by that aspect of requiring a credit card to actually go through the transaction, or sometimes even access to a digital device, right? I would say that most people have a mobile phone, even in dire straits. However, the way that mobile phone operates can be challenging. So they may not have like a internet access all the time in order to actually go through some types of digital telehealth. So I think there are limitations there. I think overall, one of the benefits is that it does exude a level of privacy. It prevents, especially in women's health, it does prevent some of the politicization that happens around women's health and affords people privacy to actually seek, specifically when we're talking about reproductive care. So there are a lot of benefits, and of course, geography, right? There are people that drive hours and hours to see a doctor for some basic things, and definitely there's benefits there. But off the top of my head, I definitely would say that access to credit cards and even just a mobile device in general that's consistent, or even having a consistent address, I think sometimes can be challenging for some patients.
Yeah, I mean, I think the one thing I would just add in there is it's also our how we approach the telehealth model, right? So currently, we take insurance. Some of our competitors don't take insurance. We also market with I would say, a very inclusive voice forward. We also, as we think about different programs you're going to start thinking about, let's just say fertility is one of them. We're going to do fertility programs, good, better, best. So let's just say you are a woman of color struggling to get pregnant, but you're not making $300-400 grand, so you can't afford these $70,000-80,000 IVF treatments. We're hoping to basically help you understand how your body works through education, through community, through coaching in an affordable program. So again, like I would say there will always be challenges, Dr. Theodore, but it's also how we try and approach to solve the problem is how we think about it. So yeah, no, we believe in the model, and we're hoping to try and hit as many patients as possible through this very digitally first model.
Good, thank you very much. When we talk about health equity, you know, as an internist, many things come to mind, and that would be one of the life expectancy of Black men in this country, about 10 years less than their white counterparts. It would also be around maternal medicine in the African American community, but also infant mortality. You know, the list can go on and on. I wanted to talk to Dr. Cook. You mentioned, you know, increasing the number of students into the various health sciences schools, whether it's pharmacy or medicine or nursing, in addition to the ability to increase the number of individuals who are reflective of the community. What are some other tactics? Because I love, and I just wrote that down around having the athlete sponsor, and I haven't thought about it in that way. Other tactics to help focus in on decreasing, big question, but decreasing some of the health inequities that we spoke about. And I would like to go around to each of the panelists just to give us your actionable items around what you're currently doing or what you can do with the individuals on the panel to help decrease the health equity gap. Dr. Cook, you want to start us off?
The first thing that I would say would be mentoring, because if a student get as far as getting into one of the schools, they are usually isolated because they are the only one of their kind. And so if we would admit at least 2 students at a time, at least they have a buddy to deal with, to help them. Then the other is to teach the teachers how to teach about cultures. I have been teaching since 1974, and I still am preaching the gospel on how to put content in the textbooks so that the students don't come out with a degree, but yet still lacking the necessary education to provide care in the community for those folk who cannot come into an acute care center. Or even if they came in an acute care center, most of the nurses do not know what ash is. They do not know how to stick a patient who is dark-skinned and have dark veins. They still depend upon their eyes to see rather than their fingers to feel. Now, those are just a few issues that the teachers need to be taught upon being asked to come on as a faculty member. The way we do it now, the metrics are the degree that you have, who you know, and how white you are. Those are the 3 major ways that we put people in. And when it comes to providing safe care, the students do not get that information because the teachers don't have that information. Safe care to me is not episodic. It's looking at the total patient, even if it takes you more than 20 minutes. And I know that in most clinics and most places, they want to run the patient through so that you can get 30 patients in before the end of the day. But I teach people, get yourself a little pad and write down all the things that you want to ask the doctor or the nurse practitioner when you get there, and start right away saying, I'm going to ask you about all of these things, and I want you to take the time to either answer them now or send me an email or send me a snail mail letter because I don't have a computer. But give me the answers to these questions so I will know how to navigate my care. Now, the other thing that people leave out, we always talk about patient-centered care rather than family-centered care. And I'm a community health person. I think a person comes from a family and they go back into that family because for first place, they cannot afford to stay in that hospital more than 3 or 4 days because it's a tremendous fee that you have to pay. And if you don't have insurance, which is my other issue, that there ought to be guaranteed methods for everybody in this rich country to get health care. None. I mean,
Par
no
none.
excuses.
Par
Because
none.
par
Yes,
none.
I
That-
agree.
But the way we have the business model set up is to make money to pay off the doctors, nurses, pharmacists, and all those people's loans while they are working for you. But I hate to say that is the wrong model to be inclusive. We need to relook at a circular model where a person comes in, they have some people in the community who mentors them. If something else come up, they can either go to telemedicine or they can go to the standalone clinics, and then they go back to the hospital, and then they go back into that circle of peace. But they are teaching all the time what they have learned in the acute care facility, and then they are teaching the acute care facility what the needs are in their community. But the thing that we do not do is we do not listen to what the patient and their family say they need. We think we know them, but they have been in that skin for 83 years rather than you being in that skin, so they know of which they speak.
Sure.
I don't want to preach, but
Well, thank you. You know, we could sit here, I could listen to you for the rest of the evening. We're going to have you back for sure on one of our panels. I do want to pivot to Dr. Nagori. I know with FemHealth, tell me how you can focus in on maternal fetal medicine now. I mean, these stats are still staggering. They haven't improved much, but your ability to do that, I know you're focused on that. Can you tell us how you'll do that and how you can partner with others on the panel?
So I want to actually go back to the original question that you had asked about how we can really bring more people into medicine, because I think ultimately will help a lot of the issues that we face with systemic racism. So we just actually launched a program at FemHealth, and I would love to collaborate with anyone here, where we link up a student that's interested in any aspect of women's health, whether it's maternal fetal medicine, whether it's mental health, really any aspect of healthcare that affects women, which is pretty much anything. And we'll link them up to a specialist in that field. So I just recently linked someone who is interested in fibroids. She has a personal history of fibroids. She has a sister who has fibroids. She wants to go to medical school. And actually she's working with a minimally invasive gynecologic surgeon, as well as an interventional radiologist who does uterine embolization for fibroids. And they're actually working together to develop content and patient-facing material on fibroids for patient consumption. So we have this program where we link up a student in any area of healthcare that they want to study. We link them to a doctor. And it's for mentorship, but it's also for them to learn in the process. So they will write about certain topics in that area, whether it's fibroids, whether it's osteoporosis, whether it's mental health. So I'd love to offer that to anyone who has any students that are interested in linking up with a physician in a particular area. And I think going back to what Dr. Cook had said, definitely bringing more people of color into medical professions is going to help to solve that problem just globally from a global standpoint.
Great, thank you very much. Did anyone else want to weigh in on that question around health equity and what you're doing specifically in your line of work to help close the gap? Dr. Kiser or Dr. Chen?
I'd be honored to say just a word. I feel like the University of Arizona, we are designated as a Hispanic serving institution. It's a national designation. And I think we are taking it to heart. So the medical school went to holistic admissions. The College of Nursing has now gone to holistic admissions, which means we're looking at more than just your grade point average, what courses you took. We have to believe once again in the power of story, which is, I think, the whole point of what has come out of this panel. You know, I had a nursing student talk with me about how in her practice interview that she'd been a refugee and she came to this country and took care of her grandmother for 8 years. And I'm immediately saying, you are the person we need to admit, that this kind of story and really understanding perspective is going to make a difference. We are strong believers that you need to have the kind of mentoring. I really loved what Dr. Cook said. So we have been funded. We have something called the Annie Grant and the NCAT grant, which is precisely to recruit and retain students of color, first generation students, specifically Indigenous and Hispanic students for our Borderlands care. And that it is a process that starts before admissions and continues all the way through your doctoral degree if you continue with us. And I think we've just had really good success. We have realized that we have to transform our faculty. So we also are looking and have applied to grants where we do exactly the same thing we did with our students. And I think most important for me and what I've really been dedicated my work to the last 3 years is you have to be able to connect people to communities that they care about. So we created that Milagro course where we're taking students from all of our health professions and they're helping to take care of and come up for solutions for our migrant communities here. But we also, and this is like the coolest thing ever, we created a binational nursing student exchange course where we have partnered with faculty at the nursing colleges in Mexico. And we are a collective and we teach the course in English and Spanish. And we specifically designed this course during the pandemic so that we as nurses, again, recognizing that this border is not real and that we have people crossing the border during a pandemic, and these solutions must be fluid. So we have created this course, we're now running it a second time, and nothing has made me happier to have people from another country that speak a different language and say we are equal partners. And not only that, the most critical message is they are leaders. Like, it is not us inviting them. We create the course together and our students get to experience what does it mean to actually talk to leaders in a different country. We also were invited to bring a team to the Navajo Nation during the worst of the pandemic. And that is the whole purpose. You take students while they're in school. 2 of our DNP students came back and said that they now want to consider working for the Indian health system. You cannot appreciate something if you do not get to meet it and know it. And the communities have so welcomed our students means that they feel like they have a role. Sorry, I didn't mean to go on too long, but we're doing some really, really moving stuff here.
One of the other things I'd like to add too is in your mentoring, make sure the students as well as the new faculty know where all the speed bumps are in the institution in which they are going. Because sometimes we admit students so that we can have the numbers, but we don't care whether they graduate. So we want to make sure that we eliminate the speed, the bumps out of the way so that the students will know, now, if you run into this, this is what you need to do. And so my role as a mentor is to help them to practice. It's like somebody said that they help them with interviews. I help them to practice. Now, if this happened, what would you do? And tell me in your own words, how would you handle it? Rather than getting mad and storming out of the room, here are some things. Take a stand, be kind, be courteous, but get your point across. Say it over and over again. And the more you say it, maybe once they will hear what you're saying that does not fit for you. So students have to be their own best advocate, along with knowing where the speed bumps are.
Sure.
And I'll
Very
just
good.
add to the discussion. Oh, sorry, Carrie, did you want to say something?
I was going to say really one
Yeah.
quick thing.
Yeah.
I was gonna say, just tell your story. So I will say for about 30 years, I never talked about my disability because it was painful. It is still is painful to talk about, and I still get teared up. But tell your story. I mean, that's how you teach people, right? So just hearing from Dr. Cook right now, telling her story. After this call, I am worn out and invigorated to go be a bigger, better, badder version of Bionic Woman than I was an hour ago. So I just, we've been taught to be almost a silent race sometimes. It's better to be seen and not heard. Use your voice. Each of our stories matter. And I would encourage all of us to share our story. So that's a Dr. Chin. Sorry, I didn't mean to interrupt.
Okay.
No, that was wonderful. I was just going to add that the pre-medical division of AMWA is probably our largest growing division right now, our fastest growing division. And we're realizing that if we really want to make an impact in the diversity of healthcare providers, we really have to start reaching earlier, giving students the support they need at the very early level so that they can, go on the path of medicine. And I was speaking with a student just this past year, and she said, AMWA was critical to my staying a pre-med. I never would have stayed the course. This is too hard. My school didn't have the support. We didn't have the health advisors. The only thing that kept me on this path to pre-med is that there was a pre-med community that I could tap into. So we're definitely trying to invest in some, individual as well as group mentoring efforts to really support women of color to come into the medical profession. And the only other thing I'll add is that all of these issues, are going to require a lot of deep thought, discussion, education. It's not just a simple matter of, okay, let's get our board of directors looking a certain color. Let's get our admission class looking a certain color. I mean, those are superficial metrics. To really make change is going to require a lot of deep work, thought, discussion, really understanding to really fix the structural problems and the unconscious biases that all of us carry.
Sure. Yes, you summed it up so nicely. I mean, the conversations that we have been having around health equity and trying to decrease the equity gap, it's not easy work, right? It's collaboration is key. But the one bother that I have is when we work in silos and we're not reaching the right people and connecting with the right communities in order to move the metric. I know that it's a lot of work that needs to be done, and I've enjoyed this conversation so much. But the one piece that I have that I just like to share is that my patience is running thin. My sense of urgency is at an all-time high around decreasing health equity, and the ability to continue to just look at data and to continue to talk. I think the time is now for us to really act and figure out what are those things that we need to do. I will tell you that the AAMC, I would love to get your feedback. We don't have that much time with the pass-fail conversion that we've done for medical students for I believe it's step 1, step 2, step 3. That actually is a way to help with increasing the number of underrepresented minorities into medical school, which should happen across the board. But it's those type of approaches that need to be taken across the nation to be intentional around ensuring that our, for instance, medical school admission rates, and to Dr. Cook's point, matriculation, you can let them in, but if you don't give them the tools you need in order to graduate and to graduate successfully and be a change in the community, it makes it somewhat trying to just meet the metric, but not really trying to change the course of their careers. I do want to stop there and give just a 30-second overview for each of you. We needed 2 hours, Carol. This is not long enough. But how about
one thing before you do that? The roadblocks that I see that we can change right away, Dr. Chin, is if a student graduates with a 3.2 from school, then they go into medical school. How come that they have to have an MCAT, which is another roadblock in order to get in medical school, if you know that they have the knowledge from the undergraduate school? let them go on into medical school without that roadblock. And we do the same thing with the GRE and the, you know, all of those other kind of things. Then when they get out of medical school, we put them up under another roadblock and say they have to go to take another test to see if the last test was not good enough, or the last 2 sets of 4 years was not good enough. Then we have to have them do the intern and extern. Are there some ways that some of those roadblocks can be knocked down to less than? I mean, the higher ed are now looking at ACT and SAT as being roadblocks. So why aren't we as healthcare providers not looking at them? My last question is, I'm working with the penal system here in Colorado, and what I want to do is educate some of the people who are incarcerated, which are close to 80% people of color. Some of those folk in Colorado, I understand, have gone in because they were selling marijuana. Marijuana is now legal in this state. So if they came out, they would still be considered a felon, and they could not take any healthcare courses. Many of those people are very sharp-minded and could do better than any of us on this panel with healthcare courses. Billing and coding, for instance. What does it take to be a billing and coder? A nursing assistant, pharmacy assistant, dental assistant, all of those things these folks could do if we would remove that barrier of them being a felon or having been incarcerated. It's not even just a felon. If they have been incarcerated, we can't even take them in as a nursing assistant school, in the nursing assistant school. So somehow that's something that needs to be done yesterday.
Yeah.
I don't mean to preach, but I get
No, I'm with you.
I get real mad about it when you go into the penal system and see all those young people, and they're mostly, at least in Colorado, they're mostly Hispanic and Black.
Across the nation.
Across the nation. Okay. I rest my case with that.
No, so those are deliverables, Dr. Cook, that we definitely want to sort of spill over into our other conversations. And Pierre will tell you that we've been holding each other accountable around what are those action items that we're just not talking every month. Let's bring those items back up next month so that we can figure out ways to really move the needle on them. And definitely the standardized testing, many people in my community from which I'm from see that as a roadblock. Just quickly, I know time is of the essence and I actually have a 5 o'clock, but I don't want to get off. I do want to hear your closing sentiments, Drs. Kiser, Chin, and Nagori. I know Carrie had to drop off. Dr. Cook gave us her eloquent closing comments. Just a quick 10 to 20 seconds of what you like to see happen under my sense of urgency that I just spelled out in this country around health equity. Dr. Kiser.
So in a word, we are definitely feeling that urgency as well. And I think that our main goal is to transform the educational process so that students are trained to deal with these issues by the time they graduate. We did create another course called the Alamos Global Telehealth course. And so that is exposing our students to global health and telehealth and learning from the leaders again in Mexico and looking at critical issues such as global justice, climate change, violence against women. If you aren't learning it in school, then you're not going to be as prepared to jump in and be the solution when we need you to be.
I didn't really speak about this much before, but I also still see patients 2 days a week. I'm a glaucoma specialist, and much of my population is Black and Hispanic that have pretty severe glaucoma. And one thing that I have made a conscious effort in my practice, which has then extended into my experience with SimpleHealth and FemHealth, is that I really take a lot of time to educate my patient when I give them the diagnosis of glaucoma. And many of them have had the diagnosis before. They come to me when they've been on one medication and they're seeking another provider. And it is alarming to me how many patients for the first time who have already been on glaucoma medication for maybe a year, maybe 2 years, maybe 5 years, it is the first time someone is sitting down and explaining their disease to them. And it is such a simple thing that makes all the difference. It helps with compliance. It helps with not just compliance with medication, but compliance with appointments, and just really getting the patient invested in the process. And it's just a very simple conversation that no one has taken the time to have with them. And so that to me has extended into FemHealth, into SimpleHealth, taking the time to explain what's going on to the patient. In any aspect of healthcare, health literacy is so important. People need to understand their disease. They need to understand why they are experiencing what they're experiencing. And it also helps with gaining more trust in the system, right? If someone doesn't trust the system, they're not going to use the system. And then there's lots of reasons they shouldn't trust the system, but for those of us that are trying to do the right thing, we need to build that trust back. And so take the time to educate your patient, to answer their questions. So just take the time.
Right.
Right.
I'm going to follow up on that. And I think what you're talking a lot about is literacy, but also just communication. And I think we just need to listen and learn from each other. I think someone mentioned earlier about the silos in healthcare, and that's something that we in AMWA are also really looking to break down the silos in healthcare so that groups can get together and work on the same issue. It's not what I'm doing, what you're doing, and everyone trying to do the same thing in parallel, but how can we come together and work together? And Carol, you and I have talked about a lot of different things that we can work together with, the work that you're doing and the work that we're trying to do. And in the end, it's not someone else's work. We have to own this, and we have to look internally in ourselves, do the deep thinking, and within our organizations or our communities and our groups, because this is a problem that we all own. It's not somebody else's problem because they have a skin of a certain color. This is something that we're all in together. So thank you so much for bringing us. This has been wonderful.
Thank you. And I'll just say to that point, Dr. Chan, that the pie is big enough, and the pie, we have not gotten to a point where we are able to have the right people at the table to eat the pie, right? And so for individuals to get to a point where it's my work or your work, we haven't moved the needle enough to even sort of determine who owns what. And we have to get to a point where we're raising the bar and holding each other accountable through that collaboration. So the pie is big enough, but we really haven't even started to eat, it feels like, and many communities feel the same way. So I'm going to turn it over to Pierre and Carol to close us out, but this has been just so heart-warming for me, very educational, as well as light bulb moments, many of them from each of you, and particularly Dr. Cook, and would love to have you all to continue the conversation outside of this setting or even as we continue. Pierre, Carol?
Yeah,
thank you.
From my perspective, not much to say, given all the brilliant and all-inspiring advice that's been given. I would just draw attention to the fact that, a generation ago when we talked about safety, that was an unusual thing to speak to in healthcare. And now it's become a standard way that we speak to reimbursement rates and the systems that we try to create in healthcare. We're focused on safety. And I hope that as we move forward, because of people just like you, that health equity also becomes a standard that we all hold ourselves to. So thank you so very much for being players in this space and for the truly awe-inspiring conversation. We all look up to you. So thank you to all the panelists that joined us today. Carol, to close us out.
Thank you. Thanks to everybody. And I just want to let you know that for our Global Minded event, we are going to have from June 7th through the 11th, a week, every afternoon at the same time. We'll have health, wellness, and health profession pathways. And next month for April, we're going to have what Pierre and Monique and I have been working on, which is how do we create that vibrant, diverse pipeline? And it starts with, early childhood. And there's a lot of ways that we can be fostering that. We have a lot of great abilities to address, allied health and nursing, pre-med, global health, all these different things. And I just love Margie's innovation. And I just think, if every board room looked as diverse as this panel, if every C-suite looked as diverse as this panel, we would have so much more wisdom. We would have so much more ability to solve major problems. And we just have to keep holding people to those standards. So thanks to all of you, and just has been such a joy to be with you guys, and looking forward to working with you over the arc of time. And Eliza, we'll schedule one-on-one, and Lisa, thank you for everything. And Margie, so fun to do our first event. She came to a Foundations and Funders event one time and then emailed me and said, hey, can you fund my prison program? And I'm like, well, I could introduce you to some people who could, but that's another piece. Like, we have to get, the money is super wealthy, white, and stuck, and it's all click-based, and we've got to get that flowing. And the tech companies just made billions of dollars in this last year as people lost everything. So, okay, Amazon, Microsoft, Netflix, Google, we need your help, and we need it now. This is urgent. So I think we all have to really like stand out there and state what we need, and then lock arms, make it happen. And I think the women are the very powerful people to pull men, women, everybody else together to do that. And this is our time to do it. So
Carol, would you announce that? Would you announce that other?
You know, I don't have it, Margie, here, but we can put it in the newsletter for tomorrow. There's an event tomorrow, like an aerospace event. I don't have it like right here because I'm on my computer.
Oh, okay.
But I'll ask Celeste to put it in the newsletter so we can get the word out to have people to come to that for sure.
Thank you.
Yeah, you are so welcome. Thanks to you guys. It's just been
it's good
such
to
a
meet you all.
treat. Bye. And we'll have in our newsletter, guys.